Okay, thank you. The Senate Committee on Health, Education, Labor, and Pensions will come to order. This afternoon, we're going to hear from two panels. We're going to hear from, on our first panel, Dawn O'Connell, the Assistant Secretary for Preparedness and Response, Rochelle Walensky, the Director of the Centers for Disease Control, and Dr. Robert Califf, the Commissioner of the Food and Drug Administration. Our second panel, we're going to be here from Dr. Reshma Manchtrandam, and we're going to hear from Robert Weissman and Martin McCary. So we have two very, very important panels. Let me begin by thanking all of the folks who are on the first panel. All of us know that the last 3 years have been unprecedented in our lifetimes. We dealt with the worst public health crisis in 100 years, and I want to thank all of you under those very difficult circumstances for the work you have done for the American people. Today, what our job is to take a hard look at where we are today in terms of preparing, God forbid, for another pandemic and the need to reauthorize the Pandemic and All Hazards Preparedness Act, or PAPA, later this year. And I want to take this opportunity to acknowledge the previous leadership on this bill from Senator Murray, who is chair of the committee, and Senator Burr, who is the ranking member, as well as the PAPA working group that I've helped convene with ranking member Cassidy, which includes Senator Casey and Senator Romney. And all of those senators have set aside time for their staff to meet with mine every week because we all understand how terribly important the issues are that we are facing in terms of the possibility of future pandemics. As everybody here knows, tragically, in the United States, we lost over 1 million people from COVID. And putting that in perspective, we lost more people from COVID in the last several years than we did in World War II. While cases, deaths, and hospitalizations are all declining, COVID is still today the leading cause of death in our country, with some 250 Americans on average dying every day. The World Health Organization reports that 7 million people have died from COVID globally, but there are experts who think that that underestimates, in fact, the number of people who have died globally. I think, to be honest, as Americans, we can understand that every public official tried their best during this COVID. God knows how hard people worked and what stress they worked under. But the truth is that we were very, very unprepared for what hit us 3 years ago. It took a lot longer for us to effectively respond to that emergency than it should have. All of us will remember that months after the pandemic erupted, we all saw pictures of doctors and nurses in overwhelmed hospitals, lacking the personal protective equipment to keep themselves healthy. We all remember those images. And we remember seeing, doctors and nurses literally using plastic trash bags because they didn't have the personal protective equipment they needed. And we also know that many, many, many hundreds of medical personnel died doing their duty, trying to save their fellow Americans. During that time, we did not have the tests that we needed to find out who had COVID and who did not. We did not have the infrastructure we needed to deal with the pandemic. All of us remember the overwhelmed hospitals and the intensive care units from one end of this country to the other. We did not have the vaccines or the treatments that the American people and people throughout the world desperately needed. We all recall that we had to shut down our schools, our businesses, and much of the economy for far too long, causing millions of Americans not only to lose their jobs, but their health care as well. So in the middle of a pandemic, millions of people actually lost their health care. And here is the scary news, and we got to face up to it. We really do, and that's maybe the most important reason for holding this hearing. What scientists are telling us is that there is a reasonable chance that, God forbid, that a pandemic as deadly as COVID-19 could occur in 10 years. All of us hope that that will not occur, but our job is to make sure that we are prepared if it does occur. That's what this hearing is about. That is what this legislation is about. The scientists have told us that there are now 7 viral families that could cause the next pandemic because they contain viruses that spread through the respiratory system and can easily spread from person to person. And our job is to make sure that we are protecting the American people. You know, we spend huge amounts of money on the military because we say, hey, we've got to protect the American people. You know what? If we want to protect the American people, we've got to deal with this issue as well. And it means that we must have a capable workforce in place, not just nurses and doctors, but also public health officials, our disease detectives. And I think we'll hear more about this in a few minutes, who can tell us where to set up a vaccination clinic, for example. If there is an outbreak developing in the West Coast, can we learn about it immediately so the rest of the country is alerted, et cetera. Tragically, during the pandemic, nearly 1 out of, and this is incredible, and it impacts not only this hearing, but future hearings. During the pandemic, nearly 1 out of every 5 healthcare workers quit their jobs and have contemplated doing so as a result of the enormous stress and burnout that they have experienced on the job. Further, we need to have accurate public health data to know who is getting sick. We need to not only have tests, vaccines, and treatments available, we have to be able to get those out to everybody who needs them. We need to make sure that our medical personnel have the supplies, the masks, the gowns, the gloves that they need. We need to have clear communication to the public, something that has been really very difficult to do. But we need to improve our communications capability. We need especially to make sure that we protect the most vulnerable people in our society, the seniors in nursing homes, individuals with disabilities, our children, and our infants. So that's where we are right now. We have experienced a terrible pandemic. Our hope is that we have learned something from that and that we'll be better prepared as we face an unsettling future. Senator Cassidy.
Thank you, Chair Sanders. Before beginning, Director Walensky, I think we all express sympathy for the family of the CDC employee killed yesterday. It's always a tragedy, but you to represent that family, we feel it in particular. Today, we're discussing an important responsibility of the committee, the reauthorization of the Bipartisan Pandemic and All Hazards Preparedness Act, or PAPA. Now, many will focus on the word pandemic, which is obviously a big part of the discussion, but we need to keep in mind the wide array of threats that this bill seeks to address, not just diseases, but natural disasters, attacks, accidents, other things that could put our country at risk. I feel connected to the origins of this bill, although I was not in Congress at the time. PAPA was first enacted in 2006, largely to address the failures of the federal response following Hurricane Katrina. And anybody from Louisiana saw firsthand the devastating impact on a community when governments are ill-equipped and ill-prepared to manage a crisis. So PAPA sought to support states, local governments, and hospitals so that they would be better prepared for future emergencies. It established the Office of the Assistant Secretary for Preparedness and Response, or ASPR, the Biomedical Advanced Research and Development Authority, BARDA, a lot of long things. Of course, you come up with awkward-sounding acronyms. And it also made improvements to the Strategic National Stockpile so that vaccines, treatments, and tests could be easily available during an emergency. In both 2013 and 19, Congress acted in a bipartisan way to reauthorize the bill, and this year, Senators Romney and Casey are spearheading this work with the committee. Now, we don't always agree, but we set politics aside and come together on reauthorizing PAPA. We know PAPA is critical to protecting the health, safety, and security of us all. As we saw during the COVID-19 response, the PAPA framework is far from perfect. Poor management and maintenance of the Strategic National Stockpile meant that doctors and nurses were forced to use expired PPE. Or one picture I remember is like a huge quantity of masks being dumped right as the pandemic was starting because they were 2 weeks from being expired. It certainly wasn't a first in, first out sort of manage the inventory type situation. And I think we can say that in some ways government hampered the private sector's ability to quickly launch tests at the onset of the pandemic, and government clearly failed, consistently and clearly failed to communicate with the public. Now, that's gone. Let's get better. We made mistakes, we learned some tough lessons, so let's work together to make it so that next time it isn't on the fly that we're figuring it out, rather there are systems that we can put into place. Update the playbook and make sure that whatever we do, it's flexible enough to address the threats beyond just a pandemic. And emphasizing, we need to look towards the threats of the future, not just prepare for that one which has already gone by. Being good stewards of limited taxpayer resources and better partners with states and the private sector so that we are all ready and willing to step in when the next public health threat comes our way. To accomplish this, the committee will need to work on a bipartisan way to enact meaningful policies to make our country safer and better prepared to work towards a consensus. I'm committing to getting this bill done. I thank you for being here. I look forward to hearing your testimony. And with that, Mr. Chair, I yield.
Thank you, Senator Cassidy. Now we're going to hear from our witnesses. Our first witness is Ms. Dawn O'Connell, Assistant Secretary for Preparedness and Response in the Administration for Strategic Preparedness and Response at the Department of Health and Human Services. Ms. O'Connell, thanks very much for being with us.
Chair Sanders, Ranking Member Cassidy, distinguished members of the committee, it is an honor to testify before you today about ASPR's ongoing work and the additional authorities we are seeking in the upcoming PAPA bill. But first, let me join the Senator in expressing my condolences for the loss of our CDC colleague. We are very sorry. Rochelle, please extend our thoughts and prayers. We are living in an increasingly interconnected world where diseases and other threats can travel quickly, unnoticed for days. We are also experiencing an increase in the frequency and intensity of natural disasters. As a result, ASPR is working on more high-consequence, no-fail missions than ever before. We are proud to lead so much work on behalf of the country and want to be sure that we have the authorities we need to continue to execute that work with the excellence, efficiency, and expertise the American people deserve. As we move out of the acute phase of the COVID-19 response, it would be management malpractice for us to look the same and act the same as we did at the start of the pandemic. I have taken several important steps in the last few months to transform our organization and to incorporate lessons learned from the COVID-19 response. For example, ASPR is now a standalone agency within HHS. This important change in our departmental status gives me the independence to build out ASPR's human resources, acquisitions, and finance infrastructure so it better supports our unique missions. I also just completed a structural reorganization that institutionalized important new capabilities like our stockpile, supply chain, and domestic manufacturing work. These capabilities that we built during COVID and need to keep using moving forward. I also made the Strategic National Stockpile an office that reports directly to me to increase visibility into and accountability of this critically important part of the nation's preparedness and response apparatus. With these changes, I have taken the two most transformational steps available to me to build a better preparedness and response organization. And now I need your help to ensure that I have the appropriate authorities to execute our mission faster and stronger. With the authorities I am requesting in PAPA, I am trying to solve three key problems. The first problem I'm trying to solve is how ASPR can procure more quickly the tools and supplies the country needs when responding to a biothreat or disaster. Early in the COVID-19 response, it became clear that HHS could not procure the products our country needed at the speed in which our country needed them. As a result, ASPR entered into a memorandum of understanding with the Department of Defense, in which they agreed to provide acquisition support on our behalf. Using their unique authorities, DoD executed more than $90 billion in contracts for us over the 3 years of the acute response. Our agreement with DoD comes to an end at the end of this fiscal year, which is why I am requesting similar authorities for ASPR. These include the ability to fund promising prototypes and then move the successful ones through the advanced research pipeline without having to recompete the contracts like we do now. We are also seeking the ability to quickly procure experimental supplies and important finished products. Each of these new authorities would allow us to do for ourselves moving forward what we had to rely on DoD to do for us during COVID. The second problem I'm trying to solve is how ASPR can continue to invest in the expansion of the domestic industrial base for key PPE and medical supplies to ensure we are never again in the position we found ourselves in March 2020, ones that you both have recognized, when our doctors and nurses did not have access to the masks, gowns, and gloves they needed. ASPR has used the funds and construction authority given to us in the COVID supplementals to build new factories nationwide to produce the PPE and supplies we need in times of emergency. These investments also provide good-paying jobs to many hardworking Americans. But once the COVID-19 funds run out, we lose our construction authority and our ability to continue investing in similar projects. That is why I'm requesting permanent construction authority for ASPR. It is important that we have funds and construction authority to sustain the work we have started and to expand this work to other parts of the public health supply chain. The third problem I'm trying to solve is how ASPR can hire staff more quickly to surge critical teams during large response efforts. In the early days of the COVID-19 response, just as we relied on DoD for acquisition support, we also relied on FEMA and the Coast Guard to bolster our response staff. The ability to hire people quickly and compensate them appropriately for their long hours and sometimes hazardous work are important tools missing from ASPR's response toolbox, which is why I am requesting direct hiring and flexible pay authorities for ASPR. Direct hiring authority will allow me to quickly scale up our response efforts so we have enough people when we need them. And pay flexibilities will go a long way towards sustaining our staff through these dangerous missions and ensuring we do not lose these seasoned first responders and subject matter experts to the private sector who pay much more and often require much less of them. To solve each of these problems I have just laid out, I have requested important new authorities for ASPR. I look forward to working with you to solve these important problems and many others as you draft the new PAPA bill. Thank you again for inviting me to testify today. I look forward to answering your questions.
Thank you very much. Our next witness is Dr. Rochelle Walensky, Director of the Centers for Disease Control and Prevention. Dr. Walensky.
Chair Sanders, Ranking Member Cassidy, and distinguished members of the committee, it's an honor to be here with you today. Before I begin, I would like to take a moment to acknowledge that our CDC family suffered a tremendous loss yesterday with the death of Amy St. Pierre, who was killed in the shooting in Midtown Atlanta. Amy was a valued member of our team at the Division of Reproductive Health, where she worked every day to save lives of mothers and infants. Our hearts are with her, her family, friends, and our colleagues as they remember her and grieve this tragic loss. In addition to the work that people like Amy do every day to fight disease and support communities, I'm here to talk about how CDC works 24/7 to protect America, and I want to thank you for this important opportunity. CDC has led public health responses since our founding in 1946, providing expertise, resources, and workforce support to states, tribes, local communities, and territories on the most pressing public health threats in the United States and across the globe. No matter the outbreak, H1N1, Zika, Ebola, COVID-19, polio, Mpox, or Marburg, CDC has been there offering world-class assistance. Alarmingly, these infectious disease threats have been emerging at an increased pace and are increasingly complex. These diseases don't respect national or state borders, and the increased frequency of outbreaks means that we should not be asking if we will face another serious public health threat, but when. For many, life has turned to normal after 3 years of COVID-19. Public health agencies like CDC and your state and local health department's mission is to continue to remain response ready to protect Americans from any resolving or emerging health threat. And we do this by actively supporting the core capabilities of public health, including state-of-the-art laboratories, a diverse public health workforce culturally competent to reflect communities, world-class data and analytics, rapid response to outbreaks at their source, and strong domestic and global preparedness. We are enhancing these capacities through an all-agency review, CDC moving forward. We're committed to addressing the lessons learned from COVID-19, increasing accountability, and improving how we deliver information to Americans. The approaching end of the public health emergency once again reminds us that policy changes and funding are essential to the readiness of future biothreats. CDC will continue to closely monitor COVID-19 and provide the information to which we have access. After 3 years of the pandemic and 3 months to prepare for the end of the PHE, we have worked hard to sustain the data to understand what's happening with the virus in America. But the end of the PHE means that CDC will no longer be able to collect data and share information many Americans have come to expect. As CDC often does, we will adapt to limitations and utilize tried and true systems to monitor other respiratory diseases to keep our eye on COVID-19. In some cases, CDC will rely on data that we have demonstrated are a reasonable surrogate, but there are data we will no longer have available because they will no longer be submitted to us. For example, certain data for a national picture of health disparities, both for race and ethnicity and along urban and rural lines. We will make do. However, this should worry us all, primarily because what it says about the visibility we will have into the next outbreak. We will be back to square one, having to build and negotiate surveillance capacity while we fight a pathogen. I know members of this committee are interested in advancing policy to close the gaps in our public health response to be better prepared for what comes next. For CDC, this means supporting the public health workforce by allowing us to recruit the best of the best through improvements in student loan reimbursement authority. We must also be able to surge staff when needed with simple changes to direct hire legislation and sufficient budget flexibility so bureaucracy doesn't stand in the way when an emerging threat arises. This also means maintaining the infrastructure our nation stood up during COVID-19 to administer vaccines effectively and quickly. The Vaccines for Adults program proposal not only provides Americans access to 14 approved and routinely recommended life-saving vaccines, but also supports a response-ready capability that we will lose without continued investment. Finally, this means modernizing data policy to support access to better quality, standardized, and timely data so individuals and families can make informed decisions about their health and policymakers can better target resources to threats before they become public health emergencies. The United States should have the most advanced and capable agency in the world when it comes to disease detection, tracking, and forecasting. It will take a more modernized, nimble, and collaborative CDC, and it will also take partnership with Congress to fully turn CDC into a response-ready agency. I am committed to working with you to better protect Americans and our national security. Thank you, and I look forward to your questions.
Thank you very much. Our final witness is Dr. Robert Califf, Commissioner of the U.S. Food and Drug Administration. Dr. Califf.
Good morning, Chair Sanders, Ranking Member Cassidy, and members of the committee. Thanks for the opportunity to be here today to discuss the importance of preparedness and how FDA can work with Congress to ensure the country is ready for the next public health threat. PAPA recognizes the key role of FDA in public health emergency preparedness and response. We have effectively used the authority provided under PAPA to support our nation's preparedness and response capabilities. However, there have been lessons learned about how these authorities could be modernized to ensure our actions could be even more effective. Providing greater transparency into supply chains and ensuring operational readiness and surge capacity within the FDA inspectorate and review staff, and improving laboratory testing regulation are priorities that will enhance national security and improve public health preparedness. First, supply chains. There's a need for greater transparency into the supply chains of our medical products to both improve resiliency and ensure continued access for critical medical products. For example, under the CARES Act, FDA received new authority to require medical device manufacturers to submit shortage notifications during a public health emergency. FDA used this information to help mitigate approximately 350 shortages. Unfortunately, these notifications will no longer be required following the end of the current COVID-19 public health emergency. However, we know medical device shortages occur in many situations that are unrelated to PHEs, including natural or human-made disasters, recalls, geopolitical conflicts, production shutdowns, and cybersecurity incidents. We also know that these shortages most often impact our most vulnerable and underserved populations like children, rural populations, and our veterans in VA hospitals. Additionally, most drug shortages were historically due to manufacturing issues that disrupted supply, for which manufacturers of drugs and active pharmaceutical ingredients, or APIs, are required to notify the FDA. The agency has relied on these notifications to help prevent supply disruptions by working closely with manufacturers, expediting review, and exercising temporary regulatory flexibility. However, we've recently seen unprecedented demand for drugs that would benefit from similar notification. The ability to require drug manufacturers and distributors to report surges in demand to FDA could help the agency to prevent or mitigate shortages, including for some critical over-the-counter drugs like we saw in the fall. Additional improvements should include reporting API sources and the extent of manufacturer reliance on certain suppliers in the drug supply chain, and ensuring FDA has an opportunity to inspect certain over-the-counter drug facilities before such products are distributed. Preventing food shortages is also critical to public health, and we're grateful to Congress for including a provision in the FY23 omnibus to require manufacturers of infant formulas and medical foods to notify FDA of potential shortages. Looking forward, extending this authority to additional categories of foods during a declared PHE could help prevent future shortages in the food supply. Second, ensuring operational readiness and surge capacity is critical in emergencies. For example, FDA could achieve more effective and efficient oversight if it had authority to require internationally harmonized master files for drug manufacturing sites and improved authorities for conducting remote regulatory assessments. Congress expanded FDA's authority to request records in advance of or in lieu of an inspection to devices and bioresearch monitoring sites in the FY23 omnibus. However, the agency could better assure the safety of products, even in times of crisis, if this records request authority were expressly extended to all FDA-regulated products. Additionally, during COVID-19, we saw the FDA staff had to be pulled off other work, and have been working relentlessly on pandemic issues, as have our colleagues, for the past 3 years, leading to a significant backlog in certain areas and to fatigue. Through the creation of a specialized program to defend against emerging pathogens and other threats, the agency would be well positioned to respond to emerging and identified threats of concern. Third and finally, the COVID-19 pandemic underscored the importance of both diagnostic test access and test accuracy and the critical need for a modernized regulatory framework that applies to all in vitro diagnostics. This will be integral to ensuring the U.S. is better prepared for the next threat and to realizing the full potential of diagnostic innovation. When I look at this list of improvements, a striking observation is that these measurements would not only help the FDA serve the public well in times of crisis, but they would also enable us to help prevent catastrophic outcomes and conduct our everyday work more efficiently and effectively. Thank you, and I look forward to your questions.
Thank you very much. Let me start off with a question from Ms. O'Connell and Dr. Walensky. Nobody can predict what the next public health emergency will be. But in a sense, our job, and more specifically your job, is to put us in a position where we can react as effectively as we can so we don't lose over 1 million people next time around. So my question is a pretty simple question, and maybe Dr. Califf can jump in as well on this one. Are we moving forward right now? Can you tell us confidently that we are moving forward as fast as we can with creating the kinds of vaccines we may need in anticipation of the next pandemic? Do we have the kinds of treatments? Are we moving? I know you may not have them today, but are we moving aggressively forward to have the treatments that we need if people become ill? Do we have the workforce infrastructure that we need? Are you confident in telling us that you can move rapidly when you learn that that we are facing a pandemic, and that you could rally all the resources that you need? Do we have the medical personnel to staff our hospitals if, God forbid, we find ourselves in the same position again? So, Ms. O'Connell, can you start off with that, please?
Chair Sanders, thank you so much for this question. This is one of my biggest worries, is that we are losing time in preparing for the next pandemic. It's the reason why the administration requested $88 billion last year to advance the American Pandemic Preparedness Plan. We did not receive that funding. We've requested again in our FY24 budget $20 billion, of which 10 would go to BARDA, to begin that research into the prototype vaccines, therapeutics, and diagnostics for those 7 viral families most likely to cause the next pandemic. You know, we were so lucky, I know it doesn't feel like it, but the one place we were lucky when it came to the coronavirus is we had already done a lot of the early work on that because of SARS and MERS. We need to get the same head start.
Are you telling us that we have not done the kind of work you would like to see us done in preparation for what may be coming?
Correct, not in all the viral families.
Okay. Dr. Walensky?
Thank you for that question, Chair Sanders. So we started with a very frail public health infrastructure from years, decades, in fact, of underinvestment. Some have estimated we have 80,000 public health work jobs in deficit right now. In fact, your own state of Vermont hired 120 people during the COVID-19 pandemic, and through our workforce infrastructure, you're able to retain, our workforce infrastructure grant, you're able to retain 12 of those 120. So it just gives you a sense of how frail and of the workforce infrastructure. In addition to vaccines...
Let me interrupt you. Are you concerned that so many doctors and nurses are leaving the profession for a lot of reasons, but including the burnout and the stress they experienced during COVID?
And public health workers, deeply. Yeah. Yes, deeply. I will also note that...
I don't mean to be interrupting you all the time. What ideas do you have as to how we can rebuild that critically important workforce?
So much of the workforce authorities that we are looking for in public health specifically, things like tax-exempt loan repayment to entice people to come in. We know our laboratory...
Can't we do a little bit better than tax-exempt loan repayment? We have a massive workforce shortage. We need thousands of new workers.
Indeed, we do. And many of these physicians, for example, come out of medical school with $200,000 worth of debt.
So that seems like a very modest... Too modest.
And direct hire authorities, flexible pay, danger pay, for example. I have colleagues in Equatorial Guinea right now on the front lines of a Marburg outbreak, and they are not getting danger pay. So these are the workforce things that we need to do to entice people to come into health and public health. So those are many of the things that we're asking for as part of this reorganization.
So what I'm hearing you say is, despite good intentions, your agency is not as prepared as it should be if, God forbid.
I would agree with that, yes.
Okay. Dr. Califf?
What I'd say, Senator, is that when it comes to technology, we are unsurpassed and ready to go with regard to drugs, devices, vaccines, tests. But when there's a profit to be made, the American industry is premier and goes for it and is producing amazing things. For the public health, we have a gap in translation, which is what my colleagues here are referring to. When there's not a profit at the end of that pipeline, we need to have the funding in order to stimulate the industry to produce these products that we're going to need for the future. And as a former practicing doc until very recently, I'm very concerned about the thing that you all referred to, and I want to stress the public health workforce, not just the docs and nurses. You lost a very important person yesterday. This is not, and it's emblematic of how hard this work is. We are way down in the workforce that we need across the board to implement. Just talk to any of your friends trying to get an appointment in a clinic, particularly in mental health these days.
Okay. Senator Cassidy.
I will defer to Dr. Marshall.
Thank you, Ranking Member and Chairman. Dr. Walensky, if you don't mind, retrospectively, what do you feel the impact of lockdowns were on mental health in this country?
It's certainly the impact of lockdowns resulted in lives saved from COVID-19, and also challenges in connectivity. And there are reports of some children doing better in school at home, but also some children that are losing.
My question is mental health.
Yeah, right, and the lack of connectivity and challenges in mental health. And we saw increases in mental health challenges before the pandemic. They were rising before the pandemic, and certainly the pandemic.
So you're saying the lockdowns had no impact on mental health?
No, I'm sorry, I'm not saying that. What I'm saying is that the impact, when you lose 1.1 million people in this country, there's tragedy, there's loss. There was loss of lives, there was loss of housing security, food security. All of these things impact mental health.
Thank you. Ms. O'Connell, recently we released a 300-page report on the origins of COVID. Senator Burr helped run that investigation. I want to give credit to the previous ASPR, Dr. Bob Cadlick, and his great efforts as well. That report says that there's a preponderance of evidence that shows that this virus was accidentally released from a lab in Wuhan, and a significant amount of evidence that would suggest it was actually made in that laboratory in Wuhan. As ASPR, what are you doing to research that same issue? Do you feel it's important that we know the origins of COVID?
So this has not been in the purview of the work that I've done at this point, but I'd be happy to take this back to the department and other colleagues that are taking a look at that.
Do you feel like it's important that we know where this virus came from?
I think it would be useful to know for sure, and I know that that work is underway. It's not being done in ASPR, so.
How would it be useful?
Well, as we work to prepare for whatever comes next, which is my job, it would be important to understand what I'm coming up against. But let me be clear, whatever it is, I'm responsible for responding to it wherever it came from.
So if a virus was made in a laboratory, your response might be different than if it came from nature.
Well, I think it would help us prevent it from happening again if we knew the source. Regardless of that, my responsibility to the country is to help them respond to whatever comes next.
Okay. Dr. Califf, I think my next question is for you. I mean, you can punt it on if you want to. The NIH did an incredible job in the early days of this COVID pandemic, sequencing the virus and then releasing and then sharing that with any group that they wanted to, any corporation. At the end of the day, 2 or 3 companies end up with a vaccine that was workable. Why did the other companies fail? Was there anything that we could have done to help promote it to other companies to be more successful? Why did we end up with just 2, maybe 3 vaccines?
That's a really great question. I wish we had like 6 hours to discuss it because, I mean, as you well know, 90% of drugs that enter phase 1 don't make it to market because Mother Nature is much more sophisticated and complicated than our brains are as we devise new therapies. So I think it was wise of the government to make a bet on 9 or 10 vaccines, and 2 or 3 made it. We often forget about the ones that didn't. I'm not sure that anything we could do would change that equation because that's pretty much the equation that we're seeing. That's why we have to do human clinical trials. We develop a therapy, we think it's going to work. All of those 90% that don't make it, somebody thought it was going to work and somebody invested. I think Senator Romney used to, I guess you didn't invest in these things. But so
I tried not to.
You have to take account of a high failure rate in this, which I think the government was very wise to do that.
But there's some value that took what the government developed to getting it across the finish line. Not everyone was able to do that, and I'm not sure what the value is in being able to do that. But you would agree that there was more than just luck getting that across the finish line for those 2 or 3 successful companies.
Oh, the collaboration and the mRNA platform that had been developed over decades and the sharing of the viral sequence, just the ability to do the viral sequence and then to use in silico methods to match vaccine to virus. That was an amazing feat of science and collaboration that made a huge difference. We would have had maybe 1 vaccine out of 10, I think, if the mRNA technology had not.
And some of the companies already had done significant investment in the mRNA technology before the COVID was even around, right?
That's correct, and that's why we're excited about new platforms that are coming along with regard to cell therapy and gene editing and other areas.
Thank you. I yield back.
Senator Murray.
Thank you very much, Mr. Chairman, for holding this hearing. Thank you. It's good to see all of you again. And Dr. Walensky, my condolences to you and all the CDC family as well for yesterday. Ms. O'Connell, I want to start with you. I am working to reintroduce my Public Health Infrastructure Save Lives Act to help provide state and local health departments with the strong sustained funding that they really need, because we know how critical it is to have well-funded, strong health departments responding to any public health situation. I have heard from my constituents in Washington State about how federal resources have helped during floods and wildfires and, of course, COVID. But states and communities still often lack the funding and the flexibility they need when they face a public health threat, especially when it comes to reaching and supporting people with circumstances that put them more at risk. And we saw this during COVID. What can Congress do to help ensure that we strategically support those most at risk in a public health emergency, including people with disabilities, older people, adult children, families?
Senator Murray, thank you so much for that question. This is top of mind for us, too. We just released an ASPR strategic plan, a 5-year plan, in which we make very clear that the country is not prepared until we are all prepared. All communities, those at greatest risk, need to be accounted for in all the planning that we do and the response that we do. As part of the FY24 budget, there's an authority to start a Human Services Response Fund, which would quickly move money into various communities to be sure that we have boots on the ground able to respond to the various populations that are most at risk. I had a wonderful conversation on Tuesday with the head of our ACL and about how important this is. So we've been in communications within the department about making sure that the human services side of our shop is also prepared and ready to respond to account for these at-risk populations. And then, Senator, you recall, as part of the last PAPA, you authorized 3 advisory committees, one for disasters in seniors, one for disasters in people with disabilities, and one for disasters in children. And we have been meeting regularly with those experts and have really valued their input. So we continue to keep this work front of mind.
Okay, good. And as you know, with any emergency, we need to be able to get supplies where they are needed most in a quick and effective and equitable manner. My Prevent Pandemics Act, which was signed into law last year, includes directives to ASPR to assist state and local health departments in accessing the Strategic National Stockpile. Can you just give us a quick update on how ASPR is implementing that provision?
Thank you. The Strategic National Stockpile, making sure that it's square, that it's fully stocked and ready to go, has been one of the big focuses of my tenure in this role. So this is an important question for us. We appreciated the provisions in the Prevents Bill, and we're working very carefully against them. We just released our 60-day guidance, which is guidance for states and localities on how they might access the Strategic National Stockpile. We continue to give technical assistance to those states that are interested in maintaining their own stockpile. What do they need to have and how do they need to switch it out? And then we're looking at all the various innovations for how we might hold our stockpile with vendor-managed inventory and other ways to switch in and switch out what we have. So this is all front of mind for us. Thank you for those provisions, and we'll continue to keep you and your team updated as we implement them.
Very good. I appreciate that. And Dr. Walensky, one of the things we really saw in COVID was that we needed accurate data. You can't get ahead of an emergency and create a response to it if you don't have that. I wanted to ask you today, can you talk about ways that your agency is working to improve data collection?
Yeah, maybe I'll break this into 2 parts. One is we are actively working on our data monetization efforts, and that is that our data highways are interoperable, that counties and local health departments can give data swiftly to us on similar highways, and we can offer it straight back to them so they can see not only what is happening in their county, but in counties around them. yielded huge returns. So before the pandemic started, we had 187 health facilities that were doing electronic case reporting. We're now at 25,000. That's about 20% of what we need across the country. So massive strides happening. Also in syndromic surveillance from our emergency departments and vital statistics from our death registries. All of this work is ongoing in our data highways. Where we could really use your help is the structure of those data is coming into us. We receive those data voluntarily. If those data don't come to us, we don't have line of sight and we can't deliver those data back. So that is among the things that we are asking for in this PAPA reauthorization. Thank you.
Okay, very good. Thank you. Thank you, Mr. Chairman.
Senator Budd.
Thank you, Chairman. And again, thank you to the witnesses for being here today. Last October, the GAO said the ASPR, or the Assistant Secretary for Preparedness and Response, needs to develop a clear approach for buying medical countermeasures for the national stockpile, regardless of whether they received development funding from BARDA, or Biomedical Advanced Research Development Authority. So Assistant Secretary O'Connell, without a clear process in place for the stockpile to buy countermeasures, will you commit to implementing GAO's recommendation to document an approach to make sure there is equal consideration of medical countermeasures?
Senator, thank you so much for that question. Absolutely. We're working closely with GAO to make sure that, that we can take into account the recommendations they make and implement them. Of course, making sure the stockpile has what it needs is a focus of mine. And we have the FEMC, which is an interagency group of experts that come together to give advice to myself and the Secretary on what should go in there across all of the various material threats that DHS has issued.
Thank you for that. You know, Congress created ARPA-H, or Advanced Research Projects Agency for Health. As it is currently outlined, many of its authorities overlap with efforts undertaken by the Assistant Secretary for Preparedness and Response, or ASPR, you. So what steps can Congress take to increase interagency coordination and remove some of the duplicative efforts between ARPA-H and your agency?
Senator, thanks again for that question. So we are really proud of the work that BARDA does, and BARDA's work is limited to developing countermeasures to make us more prepared against the threats that we see coming. ARPA-H has, as I understand it, a wider remit to develop innovative products against any disease or threat, not necessarily the national security threats that we're responding to. But it is important that we have good collaboration between our fellow agency, and we work very closely together and continue to stay in touch. But I see a very clear lane for BARDA, and it's important that BARDA stay in that lane in order to keep this country more prepared and ready to respond moving forward.
Thank you. Decentralized clinical trials, where trials take place at locations other than at a research center, like a patient's home, can make groundbreaking cures more accessible to patients who otherwise wouldn't be able to participate, simply maybe because of where they live. And we saw how important these flexibilities were during the pandemic. So, Commissioner, what steps can Congress take to reduce the barriers for patients to participate in these trials, to improve accessibility for those with rare diseases, maybe they're elderly, or they have mobility issues?
Thanks, Senator. Being a fellow North Carolinian, which has got some cities, but it's also a very rural state.
I didn't have your bio in front of me, but I appreciate the accent. I was wondering if we lived nearby.
The big city of Durham is where I've lived most of my life. And this is really important. We just put out a guidance on this. Decentralized trials are on the way. It's dependent on digital technology. So if you ask me, the most important thing you can do is to make sure the funding for internet expansion to all the rural areas. I know the bill has passed, the funding's allocated. We've got to make sure that those digital tech pipes are deployed out there. I think the methods are coming along great. You know, I spent time at Alphabet. There's no question that we have technology that everyone in this country can use. Almost everyone has a cell phone. So the methods of doing this are not requiring the big research center, unless it's a specialized area that you need special medical exams. It's the way to go.
Very good. Thank you all again. Chair, I yield back.
We owe you a minute next time.
I'll take it.
Thank you. Senator Casey.
Mr. Chairman, thanks very much. I appreciate the work that you're doing and the Ranking Member Cassidy on the reauthorization of the Pandemic Hazards Preparedness Act. I also want to thank Senator Romney for working with us on this reauthorization. I wanted to start with Dr. Walensky, Director Walensky, on supply chains and PPE. We learned a horrible lesson in the pandemic, which, to the way I look at it, kind of a national failure when we couldn't provide the kind of PPE that we needed. We don't ever want to have that transpire again. We had a buckling of that supply chain in the midst of the worst pandemic in 100 years. It adversely impacted first responders and healthcare workers, essential workers, as you know. So I think we all agree that was totally unacceptable. One factor that contributed was a heavy reliance upon imported PPE, and the dependence upon those foreign manufacturers and foreign suppliers is what drove that. It created a terrible risk that we all know that our families and our communities paid a price for. How can we promote innovation when PPE designs are outdated, and then ensure that these innovative new technologies are always available to essential workers, and whether they're in healthcare or otherwise, especially during a pandemic?
Thank you, Senator. You know, I'd be happy to have our team touch base with you about all the research that is happening at NIOSH now to ensure that we have innovation in PPE. One is our National Personal Protective Technology Laboratory that is working in sites like the one in Pittsburgh that looks at new technology for PPE that is used in healthcare and used in public health emergencies and other environmental hazards. That work is ongoing. We're working with academia in that work, and I would be happy to brief you and your staff on the work that's happening there. And I don't know if the ASPR had anything to add to that with regard to the...
Sure.
Thank you, Dr. Walensky. Senator Casey, just to say, the ASPR organization has invested $16 billion in 87 different contracts for domestic manufacturing of PPE and other critical supplies. But when we lose the COVID dollars, we lose our ability to do this construction authority and to continue to invest in similar projects. As we're seeing supply chain pinches, as Rob mentioned, across many different materials and products, it'll be important that we maintain this ability to keep this work going.
Well, thank you. It'll be a huge issue among many difficult issues in this reauthorization. Commissioner Catliff, I wanted to ask you a question about device shortages, which is another challenge. We know that in the midst of the pandemic, that was another significant strain. In particular, we saw a terrible shortage of medical devices. The FDA took advantage of the authorities that it had during the health emergency, required manufacturers to notify FDA of potential or actual shortages. How many devices, if you have this number, how many device shortages has the FDA been able to prevent using this authority?
Approximately 350. So it's a large number, and this authority is going to go away. We need it, and we need notification both with drugs and devices, not only when manufacturing is disrupted, but also when there's a huge surge in demand, so that we can help them make up for it.
Thanks very much. Mr. Chairman, I'm giving back a minute.
Thank you, Senator Casey. Senator Cassidy.
I defer to Senator Romney.
Thank you, Ranking Member Cassidy. Dr. Walensky, Dr. Califf, I interacted with you a number of times. I don't know Ms. O'Connell as well, but I respect you as individuals and physicians who have demonstrated integrity and capacity and commitment to the oath that you've taken to the nation, but also to your patients. Let me ask each of you, how many employees do you have that you're responsible for in your agency? Just go down the row approximately.
About 1,000.
About 1,000?
About 12,000 and about twice the number of contractors.
Okay, thank you.
19,000.
Yeah. I know there are some people who feel that these individuals must be corrupt or must be bad. They work for the government. They must have ulterior motives. My experience in dealing with those that I've dealt with is that they're good people. They're brothers, sisters, moms, dads, and they're trying to do the best job they possibly can. I sometimes worry that a projection that other people are evil somehow creates false impressions about how effective our various agencies are, and hope that you and others recognize that the great majority of us, certainly in this body, respect and admire the work you do. Let me ask you if there are any things you think we need to do to improve the integrity and the credibility that is held by the public for your respective agencies. So, for instance, prohibitions on owning stocks in pharmaceutical companies. I mean, I hear all the time, oh, the FDA approved that because the people looking at it were investors in that company. Is this an issue that you're concerned about? Does this exist in your various agencies? Dr. Califf?
Well, since you mentioned FDA specifically, let me just say FDA officials or employees are prohibited from owning any stocks in any of the relevant entities that they regulate. And for us, that's almost, it's 20% of the economy. So even like airlines, because they serve food, and food is a big part of our equation. So I take great pride and really appreciate what you said. What could be done to help the most is say a few nice things about federal employees. They work hard, and we can verify they work extremely hard, particularly during the pandemic. They were doing all the regular work plus the pandemic work at the same time.
Thank you. Dr. Walensky.
I would just echo the gratitude for your comments and just say that, I have an agency that is working 24/7 to take care of health and public health. They're not getting credit for it. What happens when there's a massive pandemic that affects 330 Americans is that they had a frail infrastructure to start with. They were working 24/7. Their job is to protect the public from public health so that you don't have to worry about it. So a few nice things, I would say, would go a really long way.
Thank you. I was personally concerned, and I know many others were, about the data that was available to the public from our government about what was happening with COVID, who was getting it, what age groups were getting it. I was a little dismayed that I went to Johns Hopkins to get the data as opposed to coming to the CDC or NIH or whatever, and you indicated that you're making strides to improve our systems for data collection. You also indicated that from many institutions, the data that comes is only voluntarily provided. Are you suggesting that we really need to have some kind of mandatory reporting, obviously on a basis where people can't possibly be identified personally, but do we need to do something to have a better system of collecting data and providing that to the public as well as to practitioners?
Yeah, let me just note that during the public health, right after the public health emergency, it took CDC 6 months in order to be able to negotiate data use agreements in order to receive hospitalization data, which is why the web scraping of Johns Hopkins was a very efficient way to do this while we were working with our lawyers to do data use agreements. Very similar things happen with Mpox. If we are supposed to and responsible for stopping disease outbreaks before they start, before they become emergencies, we have to have line of sight as to those when those urgent issues, those infectious threats are sparked. And the only way we do that is by getting the reporting coming into CDC so that we can, again, give it back to the communities and they know that this rare thing that they happened in their county is actually also happening in the county next to them.
All right, thank you. I haven't much time. I'd love to steal the time from the people who gave it up, but I won't do that. Ms. O'Connell, just to ask a question, one thing to stockpile, for instance, masks and PPE. It's another to stockpile the machines that make those things. How do you make a decision about whether to keep productive capacity in place as opposed to just keeping masks in place? And are we making the right choice in that regard from your perspective?
Senator Romney, thank you so much for that question. That's exactly what we're working to do now, which is make sure that the stockpile is only one part of the supply chain continuum. But, so what we have on hand in the stockpile is critical in the early hours or weeks of a response while we ramp up what we have in the supply chain, but both should work together. The hospital employees that had to, wear bandanas instead of real masks should have been able to access those on the commercial market. We're not able to. Stockpiles there to back that up should have been there to be a backstop for that. But if both are running well and we're investing in our domestic manufacturing so that supply chain is stronger and more resilient, if both are running well, we will not need the stockpile and we can rely on the supply chain. But when that gets pinched, we'll have the stockpile.
Mr. Chairman, thank you.
Thank you. Senator Baldwin.
Thank you, Mr. Chairman. I want to thank our witnesses for all your work during a very, very difficult time. And we're here talking about reauthorization of the Pandemic and All Hazards Preparedness Act. But I just want to state, not in the form of a question, but the juxtaposition of an act taken by the House Republicans last week that would result in drastic cuts to our public health programs and our research initiatives, and cuts that would undermine our nation's competitiveness as well as our safety, our public health, and our security, and leave us completely unprepared for the next public health emergency. And I certainly stand with many of my colleagues who've voiced concern about that in opposing the measure that the House Republicans passed last week. Look, in the last Congress, I worked closely with Ranking Member Cassidy on the Tracking Pathogens Act. It enhances our ability to prepare for future pandemics by strengthening efforts to identify new viral threats through genomic sequencing. Thanks to genomic sequencing, the U.S. has been able to identify, survey, and understand emerging variants of COVID-19 and other diseases, but our work really must continue. The Tracking Pathogens Act was signed into law as part of the fiscal year 23 omnibus, but unfortunately, there is no sustained funding for this work. So Dr. Walensky, can you describe why sustained funding for CDC's sequencing efforts, including through the Advanced Molecular Detection Program, is critical to preparing us for future public health emergencies?
Yeah, first of all, thank you, Senator Baldwin, for all of your efforts, your bipartisan efforts in our ability to track pathogens and to track the coronavirus through our genomic sequencing. We were doing at times tens of thousands of sequences a week so we could see, and we continue to do it now biweekly, to see where and what pathogens and subvariants are occurring. It's also the case that we know now that we have this and we can do this, that we have massive capacity to be able to do this for other viral pathogens, for bacterial pathogens, antimicrobial resistance, and fungal pathogens. So we have the capacity here to make great strides. However, again, once we've ramped this up, if we let it run dry, then we will not be taking advantage of all of that capacity. I will also note, I invite all of you to visit your state public health labs. If you go to your state public health labs, and I've been to a lot of them, you will see a really frail public health infrastructure and laboratory infrastructure. Do you have a genomic epidemiologist that can actually do this work? Do you have a sequencer on site that can actually do this work in your labs? And part of the construction authorities that I think the ASPR is talking about is to develop that capacity in your own state labs so that we can not only have the resources to do this genomic sequencing, but then have the places and homegrown people able to do it. Thank you.
Thank you. BARDA has recently begun to explore new types of platform capabilities for emerging threats. I believe that as we work to prepare for the future, we must focus on the development of medical countermeasures for viral families with the greatest pandemic potential. And flexible platforms can rapidly pivot to address previously unknown pandemic threats. That's why I've led the Disease X Act, which would dedicate resources to this particular goal. Ms. O'Connell, how can Congress support BARDA in better prioritizing the development of medical countermeasures against the viral families that present the greatest pandemic potential?
Senator, thank you so much for that question. You know, BARDA is one of the premier research organizations within the federal government, but it's an unsung hero in a lot of ways. It doesn't get a lot of credit. So I'm grateful for a question and an opportunity to talk about them. They have begun to pivot, as you've said, to this platform technology, and we're seeing some of the advantages of that in the mRNA vaccine, where you can just clip one little piece of the virus and switch it out and very quickly ramp back up production. So we're exploring that against a pandemic flu. What would it mean? We've invested $100 million to see what it would mean to transition that technology into a pandemic flu vaccine. So that work is underway. But BARDA has also asked for in FY24 $60 million for threat agnostic countermeasures, which are going, against the broad, we used to be one bug, one drug, and now we're looking at what we can do for multiple drugs against multiple bugs. And that work is underway. We have it in our budget, and we're continuing to look for different applications of the various countermeasures we're currently developing.
Thank you.
Thank you. Senator Cassidy.
I defer to Senator Braun.
Thank you. I have two questions, one for Dr. Califf and one for Dr. Walensky. I'm going to start first with you, Dr. Califf. Senator Johnson and I sent you a letter earlier this week. You've got an upcoming hearing on cellular tissue and gene therapies through your advisory committee concerning a new muscular dystrophy drug treating the Duchenne's variety of it. Unlike most hearings, this one is being done virtually. It's prohibiting the use of cameras. It's choosing from the patient segment by lottery who can speak up. And diseases like this and many others where it's very progressive, maybe has a short prognosis window, especially when there's something happening on the front that may be promising. Why would you go from the normal format to this, de-emphasizing the patient component of it?
Well, Senator, thanks for the question. The technology obviously is exciting, and this is an advisory committee, not a hearing, so to speak, and it's really following all the same rules that we have for all of our advisory committees. The goal is to have experts to give advice about the assessment of the technology as the company presents its data, and the patients have a chance for their input at the open hearing, but there is a limited amount of time, and so that's why there's a lottery. It's not a deviation from our standard procedure. We're really using our standard procedure.
And how long has that standard procedure been in place then?
Years, as best I know.
Okay.
I was an advisory committee chair 20 years ago.
And you're not reducing the amount of patient participation? It seems
not
like
that I'm aware of, but if...
I think I'd look into that. And did you get the letter that we sent to you?
I'm aware of that the letter came in,
okay.
Yes.
I think, I've been at the forefront of a Promising Pathways Act. To me, on some of these diseases that have clinical trials that are working, drugs that are promising, probably shouldn't have the same kind of dynamic as something that has less urgency, where there are at least other treatments out there. Do you view that that should be maybe looked at, keeping most of the gold standard that you always refer to, but since a lot of these windows don't surpass more than 3 to 5 years, should there be a little different way of doing it?
We completely agree on that. And in fact, in the user fee agreement that you all approved between us and the industry, we're hiring about 150 people just in this area, additional people to focus on it, because it's exploding right now with biological technology that holds great promise.
Well, that's good to hear, because it's now bipartisan, bicameral on a Promising Pathways Act with Senator Gillibrand from New York, which would address this and codify it. I'll send it to your office, and hopefully we'll get your endorsement on it. Thank you. Dr. Walensky, we've had a conversation several times in the past. Of course, we're lifting the federal vaccine mandate, the public health emergency here on May 11th. I'll not forget easily all the angst that was out in the small business community when we had to put a Congressional Review Act out to make sure you weren't going to force vaccines on employees down to employers of 100 employees. That had more fright when it was in the rearview mirror and it was coming down, and it took the Supreme Court to come in and thwart that bad idea. I'd like to know if that was your recommendation, Dr. Fauci's. It was the Biden administration that did it. Who was going to push forward that that was a good idea before we had to come in and intervene with a Congressional Review Act and then get the Supreme Court to weigh in?
Yeah, maybe what I'll say is here we are now in 2023 when we have 96% of people who have protection by one way or another, either infection, prior infection, or by vaccination. At the time, we were seeing our workforce and police departments, first responders who were...
This wasn't that long ago. This was just last year where you had maybe it won 96%, but when you and I had a conversation, we knew that it ravaged the elderly. And it was clear that it wasn't going much more deeply into the rest of the population. And the trillions of dollars that we spent and the fact that the economy was shut down for that long, I think that was much slower to react to the real science and maybe not the political science. And I'm just wondering if you and Dr. Fauci and who were the ones that kept pushing forward on that one issue of the vaccine mandate for employees, private employers down to 100 employees.
I can tell you that there's a group of us that advises the president on these presidential proclamations. I will also say that to this day, we know that our bivalent boosters still have 2.7 times the protection against death if you've gotten the bivalent boost than if you haven't. So we still know that these vaccines continue to provide protection for people across all age demographics.
Thank you. And by the way, Dr. Fauci in the last interview said that he would probably never recommend shutting the economy down again for something similar to that, FYI. Thank you.
Senator Kane.
Thank you, Mr. Chair, and thanks to the witnesses. I'm a public health data geek because like Senator Hickenlooper, I was a mayor, governor, senator, like the chair who was a mayor. We have the experience of seeing the silos, local health systems and state health systems and then federal health systems that don't really share that well with each other, and then you have all the providers too. And that created huge challenges for us early in COVID. I mean, just to kind of run back the tape, at the beginning of COVID, it was hard even to get racial information about those who were getting COVID and dying of it. And it took us a while to realize, and it took a lot of kind of jerry-rigging to realize, okay, this was affecting African-American and Latino more than others. But we didn't know that right away, and with a better health data system, we would have. Often minorities are lower income, and so they've had less health care access, which has given them more health comorbidities, which makes them more susceptible to serious cases of COVID. Often racial minorities were working in professions like home health care aides or grocery store clerks where they couldn't just go virtual all of a sudden, so they had more exposure to COVID, but it took us a while to figure that out. Then we did figure it out, and when we started to vaccinate in early 2021, beginning with populations over age 65, we figured out pretty quickly that even though it was equally available, over 65, first come, first serve, that it wasn't really equitable and it wasn't effective because the communities that were the most vulnerable needed the most were not the ones who were sitting on their computer to find the nearest CVS where they could go get a vaccine. They didn't have computer access. They didn't have the free time to do it the way some people had. But because we had figured that out, we were then able to change vaccination strategies to try to get to not just equality, but equity and effectiveness. But it's just an indication of there's a million ways where the lack of a functioning public health data system slows down our response, slows down our ability to have effective interventions, keeping people safe. I have worked with colleagues on this committee for a long time on something we call the Improving Data in Public Health Act. And some of the pieces of that act have been included in earlier appropriations omnibuses, but there are other pieces that I still think we need to include. Dr. Walensky, in your opening testimony, I heard just the back end of it when I came in. Talk a little bit, you mentioned public health data. Talk a little bit about how better public health data systems that interoperate can help the CDC do a better job and help keep us all safe.
Thank you, Senator, and thank you for your interest in this. And the state of Virginia, actually, the state of Virginia has been one of those states that has piloted with CDC and the USDS a combination of case reporting, lab reporting, and surveillance so that we do have a better window. The case that you brought up with COVID is exactly right. We were unable to see the race and ethnicity data. And oh, by the way, it happened again with Mpox. Yep. We had the same challenge with Mpox. We had a public health emergency that was declared 3 days after that. It turns out the peak number of cases, and we again could not see the race and ethnicity data. We could not see the places where vaccines were going into arms as we were trying to make decisions about a scarce resource, vaccine deployment, with my colleague here from the ASPR as we were making those decisions. We can't act swiftly, nimbly, robustly if we can't see what is happening from a data standpoint. If we wait for the public health emergencies to be declared and then state by state data use authorizations and data use agreements to happen, it takes months. It took us 6 months to get hospitalization data in COVID-19. These things, if we are to be nimble, even if we have remarkably robust interoperable data systems, if there's nothing driving on those highways, we will not be able to be nimble and see what's going on. And truly, we want to have those data at CDC so that we can give them back to state and local health departments. Thank you.
I hope as we, find a way to a big win in this area that we could include much more robust data that obviously protects people's personal identifying information, but that just gives our healthcare professionals the tools they need. Dr. Califf, I've heard a lot of from my constituents about drug shortages, and we sent you a letter recently too with about 15 colleagues just asking, hey, what can the FDA do to work with stakeholders to identify factors that lead to shortages? And I would just like you to, as I close, just tell me that I hope you're prioritizing this because I'm nervous about it.
As infant formula has gotten better, I've gone now to almost full-time drug shortages because we have hundreds of over 200 in the last year we preempted by working with the manufacturers, but that number is going up. We're keeping the actual shortages at the same level, but our employees can only plug a certain number of holes in a system, which has got real problems, particularly the generic drug pipeline. So we've got a lot of work to do. We've asked, as I said in my opening statement, for help so we have better data so that we can get out in front of this more. There's a lot more to it than that, and I look forward to working with you on it.
Thank you. Thank you, Mr. Chair.
Senator Cassidy.
Hey, thank you again. Let me echo what Romney said. I do thank all of your employees for working tirelessly through the pandemic, and I really appreciate that. Ms. O'Connell, you're a Tulane grad. Congratulations on a great football season, top 10 Senates. That's really good. So let me say that. And Ms. O'Connell, we have witnesses on the second panel that are going to suggest drug pricing policies that they say would increase access to medical countermeasures. Now, I raise that because I hear from experts that medical countermeasure development is uniquely challenging, that many of these companies are small companies, that many of the companies that BARDA contracted with went bankrupt, and others got bought by bigger companies, and that bigger companies are getting out of medical countermeasures. Is that a fairly accurate depiction of the state of the play?
Senator Cassidy, thank you for that question, and thank you for the good wishes for the Green Wave. Appreciate that. We're very proud. It doesn't happen a lot. But to your question, the type of company that we have to work with are often small biotech companies because there isn't a commercial market for countermeasures typically. So we do have to work with the smaller companies that have to come in, are willing to be innovative in a certain way, willing to...
Can I stop you for a second? It's my impression that a lot of those companies are living on venture capital and actually have not turned a profit before their first big product. Again, is that a fair characterization?
We often support the work that they're doing in order for them to be able to be successful.
Now, if you were to put restrictions upon what medical countermeasure developed could be priced for, perhaps without knowing all the variables, and if they're, in this example, because I think it's a fair example, that there's really no secondary use, it's for this particular issue. Would that be encouraging of the financing, the private financing of these firms, or, if you will, discouraging?
Well, let me first say that we remain committed to making sure that any government-funded
I got limited time.
countermeasures are available to people, to everyone in America that needs them. So we're very committed to that. But there is a risk if we were to add some limitations in the contracting that we limit the number of companies that are willing to come forward and do this work.
You would limit the number of companies, and the number of companies is already limited.
There's a risk.
Yeah. Dr. Califf, good to see you, man. You're looking fit, man. Let me just compliment you right off the bat. Another suggestion as regards how to develop some of these products is to incentivize innovation with an X Prize, a large sum of money, but that would be in lieu of patent and regulatory exclusivity. I don't know if you can comment on the finances of this, but do you think an X Prize would be an adequate substitute for one of these companies in lieu of the patent and regulatory exclusivity?
Well, you know what a complicated question you just asked, and what I'll say is the prices of drugs, innovative drugs, I believe are too high, but the solution to that problem shouldn't, in my view, be to do away with patents they serve a vital role in stimulating the kind of thing you were just discussing. But where the balance is between those two and the role of prizes, that's a longer discussion. I don't think it's an either-or situation.
But in general, the intellectual property protection plays a critical role in incentivizing innovation.
Absolutely, and we just got sued today again by a company over that issue, so it's very important. If people are going to invest in these companies, there has to be intellectual property protection.
Ms. O'Connell, I'm going to ask you a question somewhat related to the last. There is a conversation about having what is called, quote, reasonable pricing, quote, clauses that would dictate the price of something should it enter into the commercial market. Now, in general, is there a commercial market for most of the things which BARDA is funding?
In general, there hasn't been. Of the 70 products that we've had licensed, very few of them are available on the commercial market.
Now, I think I have data showing that the NIH had reasonable pricing clauses from 1990 to 1995, and after they removed them, the amount of, here's the kind of production of drugs, and then they removed it and it took off. Now, that may be an association, not a causation, but in your sense, do you think that a reasonable pricing clause would make a company more or less willing to work with BARDA on medical countermeasures?
We'd have to take a look at that, but like I said, there would be a risk in adding an additional contracting element to the work that we're doing.
I have more questions, but I have no time. Thank y'all.
Well, the questions you raised are very interesting, and I look forward to discussing them in the future. Senator Markey.
Thank you, Mr. Chairman, very much. So earlier, I think, Dr. Lewinsky, you said that, by the way, congratulations on the great year that the Harvard football team had up there. So congratulations. There's kind of a tale of two pandemics here, with 250 people a day still dying. And so can you talk about that cohort, who they are, and what the message is to them as the medical emergency in general ends?
Yeah, so as the public health emergency is set to end next week, I do want to just reiterate that we at CDC are not changing the steam at which we are working through this resolving public health emergency. As we look at the kinds of people who continue to pass from COVID-19, they tend to be elderly, they tend to be more vulnerable, they tend to be those who are not vaccinated or not up to date on their vaccines. As we look at those numbers, the more fragile people and people who are not up to date. It is the case at the end of the public health emergency, we will have less window as to the data. That is among the things that we've been talking about. We will lose our percent positivity. We won't get laboratory reporting. We won't get case reporting, so we'll lose some of that. With regard to what we are doing as we talk to these vulnerable communities, we've been doing a lot of work in CDC to address our disabled communities, our vulnerable communities, our elderly communities. Among those things is with every response now we have a chief health equity officer and a disability officer. We've been working with our colleagues at ACL. We actually have a meeting tomorrow to discuss with the disability community the impact of the end of the public health emergency and what that means. We've been putting disability experts working with our partners to put disability experts within states so that they have resources and references within their local communities to understand the impact of COVID-19 and other respiratory threats.
So for that cohort, people over 65, people with pre-existing conditions, immunocompromised, they still have to act as though the pandemic is still going on in terms of protecting themselves, because you can be in a culture where everyone else is saying we're back to normal, right? But for them, it's not back to normal in terms of what they need to do to protect themselves. Is that the message?
And in last week, actually, we provided an update to the bivalent boosting recommendation so that that community could actually get access to another dose. And as part of the end of the public health emergency, among the things that we would like to do is provide data on hospitalizations, local data on hospitalization, so people can see the hospitalization rates happening in their communities and make decisions as to whether and when they want to take extra measures.
Thank you. So they should still act as though they're still in a pandemic in terms of the vaccinations, the bivalent protections. Yeah, I think that's a very important signal because it is a tale of two pandemics. Those people are still out there. At 250 a day, that's 1,700 a week times 52 weeks a year. That's a lot of people who are going to be affected. Dr. O'Connor, the planet is sick and there are no emergency rooms for planets, and we see the effects in New Orleans, in other places with climate change just having devastating impacts on communities, which then affects the healthcare system in those communities and could be delaying or denying people access, for example, to opioid treatment, methadone treatment, whatever, when they when this storm hits, when the system collapses. Can you talk about what you do in order to make sure that that system is strengthened or needs strengthening across the country? Because we can really predict, almost guarantee, that we're going to see intensifying storms in our country. And all experts, all meteorologists, climatologists are saying that. What do we need to do for our public health system to make sure that it is more capable of responding?
Senator Markey, thank you so much. We are seeing an increase in storms. In fact, FEMA talks about a polycrisis state where we're seeing the increase in flooding and fires, the intensity of storms that are happening. So we are continuing to ramp up our response elements, and that's one of the reasons why the authorities we've asked for in the new PAPA bill are so important. They would allow us to hire more responders, to get more people on the ground, surge quicker, be able to procure the tools we need in a faster way. So we're looking across all of those things in the new landscape that we're living in to make sure that we are strengthening what we need to have on the ground.
Thank you, and thank you all for the historically great work which you did to have our country respond the way it did. So thank you so much, and we'll try to get you the additional resources you need. I think your recommendations are going to be well received. Thank you.
Thank you, Senator Markey. Second, Senator Hickenlooper.
Thank you, Mr. Chair. And thank all of you. It's been a while. Dr. Califf, I'm not sure you're looking that fit, with all due respect. Look a little tired. Obviously, you're doing one of the hardest jobs you all are, and certainly making sure that we get PAPA put back together the right way with the proper resources is going to be a big deal for all of us. We take that very, very seriously. Obviously, it's how could we do otherwise? Dr. Califf, I wanted to start, and obviously an effective regulatory partner is key to getting these platform technologies to the public in the context of a pandemic. The FDA has proposed a specialized program to handle the emerging pathogen preparedness in your priorities for fiscal year 2024. Can you speak to your vision, specifically how the agency might be able to handle the unique regulatory considerations for these platform technologies?
Sure, we're constantly looking. I mean, we've had a good discussion here today about platforms and how important they're going to be in the future, where you can mix and match and insert a new element and come up with a new therapy in a very short period of time compared to what it used to be. That's a reality with messenger RNA, but there are many others. So we are asking for a team of people that are dedicated to this, who can be looking to the future. It's included in some of the things already in play, but we want to do more of it so that we have these platforms ready to go. And then you can depend on the platform. You don't have to redo all the regulatory work that you would do if you were developing a drug from scratch. Let me also quickly mention, relative to several other questions, I'm 71. I got my bivalent vaccine a few days ago, which is why I look a little tired.
I was just kidding.
I threatened to wear a sawed-off T-shirt as a demonstration project. I still have the Band-Aid, but my staff told me that was not allowed in a Senate hearing.
Let me suggest you go and have a 4-month-old child at home. Then you'll be really tired. Dr. O'Connell, or Assistant Secretary O'Connell, sorry. COVID had obviously these immense costs we've gone over again this morning. Economic costs, human costs, and I do think important work will be done as we look back over the entire arc of this pandemic. And again, I can remember vividly, I was just a couple years out of being the governor, and so I watched the decisions that were being made by governors all across the country and by all of us in Washington in real time with unbelievably limited information. In other words, the data just wasn't there, the fact set wasn't there. But I think it'll be useful to go back and look, given at each time what information we had, did we make the right decisions? And I think we should be upfront saying that that's there is no harm in that. Mistakes in a time of crisis, it's impossible to get everything right. One thing we did see was that regional coordination and resilience were and are key to weathering future pandemics. Colorado, we've got the big city hospital, Denver Health, has been a successful demonstration site for both the Regional Disaster Health Response System and the National Special Pathogens Program. But neither of these have gotten permanent authorization. They're just test cases. So can you speak, Assistant Secretary, as to the success of these programs, but also what the likelihood is in terms of getting more continuity there?
Senator, thank you for that. I think you're absolutely right. We've built this system where we looked at coalitions locally and then expanded out regionally and then, across nationally. And frankly, COVID was one of the first major responses we've dealt with that we've needed a national response immediately. So to be able to have these strong places within the country to lean on have been really, really important. You mentioned our regional disaster response health systems. At this point, we've only funded 4 of those. So only 4 regions have the benefit of what Colorado has. One of the goals I have is to be able to expand that so it actually is national, and we have one of those in each region that can make sure we're coordinating across. And you see how important that is in something like COVID. When the ICUs were overwhelmed in one hospital, to know where to go within the region and the next one that could take a bed was critically important. The RESPTCs, the National Special Pathogens that you mentioned, those came out of the Ebola response in 2014 when we realized not every hospital could handle an Ebola patient. So we set up this system across the country of regional locations that were able to take those patients, and we have trained them and continue to work them, and I'm really proud of the success that they've had. In fact, unfortunately, we've had to exercise them recently with the Ebola Sudan outbreak in Uganda and the Marburg outbreak we're seeing in Tanzania and Equatorial Guinea. In case anyone came back, we needed to be sure we were ready to handle and treat. Right. So very important capabilities.
Well, I think we saw a lot of that also, the regional response and resilience came from community health centers as well as the hospitals as well as the research places. I mean, that did show the strength of our public healthcare system. I'll leave each of you, I'm out of time, so you just have to think on it. But as we try to build the various platforms and build a pandemic preparedness that's worthy of the words, I think we've also got to be vigilant on the creep of red tape and bureaucracy, and already I'm beginning to hear people saying, "Oh my gosh, to apply for this or talk about that." There's so much paperwork, there's so much process that we've created because people are so worried about making a mistake, and that's why I think it's important as the Senate reviews the strengths, the successes, the failures, the misses, the hits, that we realize we're never going to get it perfectly, but there is real value to constantly be trying to find ways we can limit the red tape and the bureaucracy, especially in the FDA. I think there's endless work to be done. Anyway, thank you all for your public service.
Okay, thank you, Senator Hickenlooper. And that is, I think, our last questioner, and we thank the panelists very much for being with us today. And now we'll hear from our next panel. Shouldn't we be saying something before we introduce witnesses?
No. I mean,
why not? How is it different from?
Well, that's how we've always done it. I mean, if you
want
to
change the rules.
Okay, if you want to say something.
Yeah, I'll say a few words. Yeah.
Okay.
Let's convene our second panel, and we thank our panelists for being here and for sitting through the first panel. Before I introduce our panelists, let me just say a few words. I think sometimes it is important to take a 30,000-foot look at the systems under which we live. And we don't do that often enough. We deal with crisis by crisis. In my view, we are living with a healthcare system which is broken and which is dysfunctional. We spend twice as much per capita on healthcare as any other country on earth, $13,000 every year, which is unsustainable. And yet, despite that, 85 million Americans are uninsured and underinsured. We are seeing in many parts of this country, unbelievably, above and beyond COVID, a decline in our life expectancy. We have 500,000 Americans who every year experience bankruptcy, which is related to the medical debt that they have. And we saw during the pandemic how unprepared we were for the major healthcare crisis that hit us. There are a lot of reasons for the dysfunctionality of our healthcare system, but one of them, to me, is the outrageously high cost of prescription drugs in this country. And what that means is that 1 out of 4 patients who receive a prescription from their doctor are unable to afford to fill that prescription. How absurd and counterproductive is that? Because too many cases, these folks are only going to get sicker. Maybe they end up in the emergency room at a higher cost to the system. We see Medicare costs are extraordinarily high because they pay very high prices for the prescription drugs that they dispense, meaning that our deficit in national debt goes higher. Add all that together, we are losing about 60,000 people a year unnecessarily because they can't afford the medicine they need or get to a doctor on time. So the questions that we have got to ask ourselves is, where is our current prescription drug model working? Well, I guess it is working for the pharmaceutical industry and the PBMs, because they make tens and tens of billions of dollars a year. Their CEOs make compensation packages of millions of dollars a year. And yet millions of people cannot afford the outrageously high prices that we pay. So the questions that we have to ask is, how does it happen that we pay by far the highest prices of any major country for prescription drugs? I have been with Americans going to Canada where they got their medicine they needed at 1/10 the price they're paying in the United States. All right? So what I hope we will discuss is the dysfunctionality, in my view, of the current model and how we advance to another model which does what we all want to do. Do we all believe that it is terribly important that we have cutting-edge prescription drugs to save lives, to ease pain? Yes, we do. Do we all understand that the best drug in the world is meaningless if somebody can't afford it? Do we all understand that we have a huge deficit, which is in some ways attributable to the high cost of health care and prescription drugs in this country? What are the tools that we need? What should we be doing that other countries do, where they provide prescription drugs to their people at a fraction of the cost that we pay? So those are some of the issues that I hope we will be discussing. Senator Cassidy.
Thank you, Chair. Well, I've been so efficient, I put away my opening remarks. Let's wing it. Thank you all. You'll each bring a unique perspective to this issue. We emerged from the pandemic with an understanding that however robust PAPA was in the past, it was not adequately robust for the pandemic through which we just went. They always say that generals fight the last war. I think our generals actually plan for the next. In a sense, you're the generals who are helping to plan for the next war. Now, there's some things that we'll be considering here that are traditionally a little far afield from PAPA, but that's just the way the committee has been convened. But nonetheless, I look forward to your input, and you're all, by the way, very impressive resumes. So let me just thank you all for giving of your time to be here. Thank you.
Okay, thank you, Senator Cassidy. Our first witness will be Dr. Reshma Ramachandran, who's an assistant professor of medicine at the Yale School of Medicine, an expert in ensuring equitable patient access to safe and effective health technologies. Dr. Ramachandran, thanks very much for being with us.
Chairman Sanders, Ranking Member Cassidy, and distinguished members of the committee, thank you for the invitation to testify today. My name is Reshma Ramachandran. I'm an assistant professor of medicine at Yale School of Medicine, where I co-direct an interdisciplinary research and policy program called the Yale Collaboration for Regulatory Rigor, Integrity, and Transparency. I'm also a primary care physician at a federally qualified health center in New Haven, Connecticut. I'm honored to testify before you today. My remarks reflect my own views and not that of my employers nor the organizations I work with. In 1 week, the declaration of COVID-19 as a public health emergency will come to an end. With this year's reauthorization of PAPA comes an opportunity to reflect on this period and utilize the lessons learned from dispersing significant public investment that led to the rapid and successful development of vaccines and therapeutics. To inform this legislation, Congress should answer the following fundamental question: how can we ensure that the American public has equitable access to medical countermeasures developed in response to public health emergencies in the future? Looking back at the COVID-19 pandemic, the federal government effectively removed manufacturers' risk of developing and producing urgently needed vaccines and treatments by granting direct public investment as well as access to scientific expertise and resources across agencies. In return, however, the American public who underwrote these investments have received little guarantee that they will have equitable, sustainable access when the public health emergency period ends. Instead, manufacturers have announced their plans to raise prices exorbitantly, ignoring that at even lower pandemic prices, they've been able to reap billions in profit. Without intervention from the federal government, my most vulnerable patients, including those without health insurance, as well as those at higher risk of severe illness, will disproportionately bear the burden of such untethered price hikes. While current policies offer some measure of protection for insured Americans in removing cost-sharing for vaccines, they too will likely confront these prices indirectly in the form of higher premiums. The federal government, in procuring vaccines and therapeutics, will also bear these expected increased costs. Further increasing taxpayer spending on these publicly funded medical countermeasures will mean that there will be less money and resources available for other critical public health interventions to prevent future resurgence or address other threats. Moreover, based on trends that we studied in public and private procurement of another publicly funded vaccine, that of influenza, these initial COVID-19 vaccine prices following the public health emergency period will likely be the floor for continued price hikes in the future. So what must Congress include as a part of PAPA to protect the American public and their investment? First, Congress should empower the federal government to exercise necessary leverage when allocating funds for the development of medical countermeasures and negotiating procurement contracts. Through bulk purchasing agreements, the government could mitigate the impact of substantial price increases through a negotiated lower price, as they did during the COVID-19 pandemic. To further prevent these prices from continually rising year after year, as they have with other vaccines, the government should call for a ceiling price to be upheld. Additionally, similarly to what they have been able to negotiate in a few contracts, the government could also ensure that manufacturers give them the best price compared to that of other high-income countries. Besides securing reasonable pricing provisions, the federal government must not sacrifice access and compliance safeguards within these contracts under the guise of flexibility and speed. Use of contracting mechanisms such as other transactions authority hinder the ability of the federal government to remove unnecessary access barriers to taxpayer-funded medical countermeasures such as unaffordable pricing. Instead, allocation of any such funds should be tied to provisions that confirm that the supported medical countermeasure is indeed safe and meaningfully effective. During an ongoing public health emergency, it may be acceptable for residual uncertainty of these products to remain at the time of market authorization. However, the federal government must condition taxpayer funding on the completion of additional studies that verify that they do indeed work as intended and that answer other important public health questions beyond FDA authorization and approval. Understanding how different treatments and vaccines compare to one another or across different populations would better inform the government in determining how many doses to procure of each individual product and at what price. Without a doubt, COVID-19 demonstrated how effective the government can be in spurring the rapid innovation of medical countermeasures. However, the success of these efforts should not only be measured by whether these medical products reach the market. Rather, Congress must ensure that the success under PAPA is redefined as the government acting as an effectual steward of taxpayer funds and ensuring equitable access of truly effective and safe health technologies in return. Thank you.
Thank you very much. Our next witness is Mr. Robert Weissman, who is president of Public Citizen. Mr. Weissman is an expert on drug pricing and specifically ensuring equitable access to drugs. Mr. Weissman, thanks a lot for being with us.
Thank you very much, Chair Sanders and Ranking Member Cassidy, for the opportunity to be here today. I think it's fair to say that Operation Warp Speed was a great success in speeding the development of COVID vaccines and a validation of the BARDA investment model to an extent. But it was also a great failure, and we need to learn that lesson as well. It was a failure in that although the US government was responsible for funding of the COVID vaccine from before COVID even emerged, through the isolation of the key spike protein, through the clinical trials, and up through the development and production of the vaccine, BARDA imposed effectively no restraint on how Moderna and other partners, but especially Moderna, would operate. The result was, while Moderna executives became billionaires, taxpayers were price gouged. Hundreds of thousands or maybe millions of people lost their lives because we had a global shortage of a vaccine that could have been avoided if we had shared the technology. And now Moderna has announced it plans to quadruple prices, further limiting access, further gouging consumers, further gouging the taxpayer. As everyone here has agreed, we need to learn the lessons from what happened during the pandemic period and do better going forward. We absolutely need PAPA, we need BARDA, but we need to do better. What are some key lessons going forward? First, we need more transparency in the contracting process. Taxpayers should know who they're providing grants to, who are they making acquisitions from, and on what terms. When drug companies and vaccine makers are making co-investments in a product, they should know, taxpayers should know how much is being done on the private sector side along with the public side. Second, we need to have reasonable pricing for the products that we, the taxpayers, pay for. That should just be common sense. If we pay for it, we ought not to pay for it again with unreasonable prices. The starting point for reasonable pricing should be that the United States does not pay more than other high-income countries do for a product, but that's just a starting point. We can do much better than that. In general, the way we should think about reasonable pricing is tailoring a reasonable price to the amount of private sector investment and risk taken. Where the government pays for the development of a drug all the way through, the reasonable price should be a lot lower than where a private sector partner took on a lot of the risk and made a lot of early stage investments. Third, we have to guarantee international access. We know that pandemics definitionally mean that everyone around the world needs the products we're talking about. Drug manufacturers, vaccine makers may not have capacity and often don't have interest in serving the global markets. As such, we should have a proactive requirement for licensing to the World Health Organization of crucial technologies and licensing and sharing of technology and know-how as well to make sure that other manufacturers can produce products that everyone needs. Last, we should consider, as well as the traditional model for supporting research and development, prize models, such as those that you've supported in the past with legislation, Chair Sanders. We know in the case of BARDA that the patent monopoly model of support innovation by definition doesn't work. That's why BARDA is making the investments, because the private sector model in these cases, as Commissioner Califf has said earlier, doesn't work. It's at least insufficient. Given that, we ought to think creatively about what might work better. Prizes can be calibrated to provide appropriate incentives sufficient to enable manufacturers and researchers to enter the space, while also ensuring affordability and access on the back end. Can also do other things to promote innovation, like giving people rewards when they don't actually get the final product, but they make contributions along the way. So these are some of the lessons I think that come out of the pandemic and that we must incorporate into PAPA going forward. Thank you very much.
very much. Senator Cassidy, did you want to introduce your panelists?
We're joined today by Dr. Marty Makary, a surgeon, researcher, and professor at the Johns Hopkins School of Medicine and professor at the Johns Hopkins Carey Business School. Dr. Makary focuses his research on public health and healthcare delivery issues ranging from healthcare costs to COVID-19. He previously worked with the World Health Organization, where he helped develop the surgeon's checklist, which has helped reduce surgery-related deaths around the world. He holds degrees from Bucknell, Thomas Jefferson, and Harvard universities, completed his medical training at Georgetown and Johns Hopkins, and is the author or co-author of over 250 peer-reviewed papers. Did I get that right, man? Yeah, pretty impressive. I look forward to hearing from you today. Thank you for joining us, Doctor.
Thank you. Thank you, Senator Sanders. Thank you, Ranking Member Cassidy. Thank you, Senator Markey. It's a privilege to present. I speak on behalf of myself, not Johns Hopkins University or the National Academy of Medicine, of which I'm a member. Congress should avoid the false narrative that insufficient federal fundings were to blame for our pathetic COVID response. Take, for example, one Johns Hopkins student created a COVID tracker that the world used, and it was not created by the 21,000 employees at the CDC. As a matter of fact, when HHS met with the CDC, they said it would take months to create such a tracker. Did the CDC need 25,000 employees or 50,000 employees? We just had the head of ASPR, the Assistant Secretary of Preparedness and Response, say she needs more hiring power. How about firing power for incompetence or both? I mean, 21,000 employees cannot come up with a COVID tracker. More tragically, the NIH has $42 billion. BARDA, which is a part of the PAPA Act, has another $1 billion, and they couldn't do the most basic clinical research we needed done quickly to answer the basic questions, to end the controversies and the conspiracy theories, to finally get at the questions Americans were asking us: how does it spread? Is it from touching surfaces? Do I need to pour 20 gallons of alcohol on my groceries? Fauci was telling teachers in July to wear gloves and goggles. Or was it spread airborne? That could have been answered in 24 hours in one of our BSL-4 labs, or in 1 week of clinical research to answer the question, when are you most contagious? What's the peak day of viral shedding? How long do you have to quarantine for? Do masks work? We could have answered this with definitive basic clinical research early. They didn't. And so I think it's fair to ask, how did they do in preparing us for the pandemic? We've spent over $20 billion on PAPA over the last 20 years. What has that done for us? How many lives were saved during the COVID pandemic because of investments by PAPA or BARDA? Now, they've done some good work. I've seen it. But regardless of one's political affiliation, they've got to acknowledge that we doctors and the public were flying blind. We had opinion ruling the day on what we should do or not do when we could have been governed by evidence, policy driven by good basic clinical research. We didn't have that, and so we had a void of clinical research, and guess what filled that void? Over half a year, 2 years, what filled that void were political opinions. Yeah, but he's not. Those controversies could have been ended early. We had the money, and as a result, the COVID pandemic became the most politicized pandemic in U.S. history. It was avoidable. Much of it was avoidable. My research team at Johns Hopkins did a study of where the NIH spent their money in 2020. They spent 2.2 times more money on aging research than they did on COVID research the year of the pandemic. Now, I'm all for aging research, especially as I get older, but not during a global pandemic when 3,000 Americans are dying a day. Much of this research was misguided, and our study published in the BMJ that I included in the packet showed that it took the NIH, after they decided to fund a research study, it took them 5 months to give that money to the researchers. That does not work during a health emergency. Now, while the NIH is outside of the scope of the reauthorization, BARDA is. And I think the public has a right to ask, what has BARDA and what has PAPA done for them in preparing for COVID? How many lives were saved because of the investment? What's the single best investment BARDA made with that roughly $20 billion before the pandemic? That saved lives during the pandemic. I think it's fair to ask those questions. How many beds are available today? Do we track the number of beds available? We're going to have more catastrophes, not just viral pandemics. We're going to have mass shootings and floods and other natural disasters. We've spent a lot of money at BARDA making hospitals a lot of money, giving them a lot of money, private startup companies making money, contractors making a lot of money. But the question is, where was the basic clinical research? We've been funding virus hunting internationally, sending teams to get exotic viruses and bringing them back into populated areas. How about funding basic clinical research? Thank you, Senator Sanders and Ranking Member. I look forward to your questions.
Thanks very much. Let me start off with an issue that has bothered me for a long time. It's kind of a philosophical issue, maybe a moral issue. If I have a product, a prescription drug or vaccine that can save his life, and I say, Bill, you can have it, but it's going to cost you $100,000. And you say, hey, Bernie, I don't have $100,000. And I say, well, I'm sorry, Bill. My business model is, that's the price. Sorry, you're going to die. Nice guy. That's the way it is. Now, Mr. Weissman, you were talking about maybe millions of people around the world, poor people dying because they didn't have the vaccine. We have it. And I think the vaccine, as I understand it, somebody correct me if I'm wrong, now costs a couple of dollars to produce, not a whole lot of money. What is the morality, and I want all three of you to respond to it, of us having a product that costs a few dollars to produce, but not making it available to people around the world who are dying, and in our own country as well, but poor people around the world? Doctor?
Senator Sanders, what you're describing, the situation, the hypothetical, is the lived reality. I see it pretty much every single time I have a clinic where patients come to me and say that they can't afford whatever I'm prescribing them. And the fact that this could happen with a publicly funded vaccine is frightening, frankly, to me, after the public health emergency period ends. So, absolutely, I think, it should be unconscionable. It should not be allowed for that to happen. No one should be poor because they're sick, and no one should be sick because they're poor. And
if I have a product that can save your lives that costs me a few bucks to manufacture, should I deny it to you?
No, definitely not.
Okay. Mr. Weissman?
Well, thank you for the question. It really is a core one. It's obviously an unconscionable scenario that you're describing. I think when we look at it globally, what's worth underscoring is that there effectively is no market in low and middle income countries for big pharma. They're not holding out to see if someone can pay more. They're just not going to sell there at all. So leaving aside what we think about should happen in our own market or in high income country markets, in those markets, we just have to figure out ways to get the technology disseminated there. And when it comes to life-saving technology like a vaccine, especially a US government-supported vaccine, if they don't want to make it to sell there, fine, but require them to share the technology with other manufacturers, give them the know-how so they can make it on their own. That's the least we should obligate.
Mr. McCary, should people die because they can't afford a product that costs a couple of bucks to manufacture?
Cost should never be an access barrier. However, I must note that there are sacred cows nobody will talk about with drugs in the United States, like
Test me.
Pharmacy benefit managers and group purchasing organizations.
We'll talk about it.
So thank you for your work on
We're
that.
going to have them next week. They're going to be sitting exactly where you are sitting, along with the three major insulin manufacturers in the world. How's that?
Great. Sole supplier contracting is also tied into shortages. The FDA commissioner was just asked about shortages and what he's doing, and he said we need better data. How about these mass monopoly powers? We've got 3 suppliers that supply 85% of U.S. hospitals. They enter into these cozy sole supplier contracts. The manufacturer gets a flimsy supply chain. For something like insulin, we have maybe one manufacturer.
All of the points you're raising are good points. I want to get it back to you. Tell me about the moral issue. I have a product, cost me $2 to manufacture, will save his life. He can't afford it. Is that a moral business model that we should sustain, in your judgment?
It's an unacceptable barrier, but I think the best way to lower drug prices in America are to stop taking drugs we don't need and to cut the waste in the system.
Okay. Senator Cassidy.
Thank you all for being here. Dr. McCary, what do you really think, man? Well, of course, the theoretical that was just given is an absurd theoretical. I say that because Moderna has already pledged that they will make this drug available. I come from treating a group of patients who were uninsured in Louisiana. I speak with some authority. Between a Medicaid expansion state and 340B and other mechanisms, drugs should be available for those who otherwise would not have. Now, as regards the vaccine, I could also give you a theoretical. What if we so disincentivize the production of cutting-edge therapies that somebody would not develop it? Oh, we've seen that before, haven't we? And what happens is we end up not having cures. So I think that we have to have a note of reality as we give theoreticals. Dr. McCary, in full disclosure, I had a very productive conversation before the last hearing with Dr. Walensky. One concern I had, there seemed to be, and by the way, I think in fairness, we have to say the federal agencies to which we refer generally conceded didn't do well, some of them at least, before the pandemic, but they're making major efforts to reform. So let's just acknowledge that. And one of the productive conversations I thought we had is how you could have information sharing, that it wouldn't be siloed or, if you will, quarantined from others seeing it by a federal agency, but with sufficient protection of privacy, that there would be access by other researchers who might have a different idea than CDC. You are a person, I think all three of you are people who have different ideas about how these things should be handled. And so, again, with sufficient protection for privacy, having access to that database. CDC may maintain it, or someone else, but some good researcher at Johns Hopkins who wants to test a thesis could similarly do so, one more time with appropriate safeguards. What are your thoughts about that?
Public health officials really downplayed and silenced dissent on many different levels. Why has the Oxford-AstraZeneca vaccine never been approved in the United States? Being given to over 1 billion people? Covaxin, why has it never been approved? What is it with the cozy relationship between regulators?
Yeah, but go back to the information sharing, because that's the point of my question. So, is there a way that we can have more kind of group outsourcing or group sourcing the analysis of the data that would allow us to make better public health decisions?
Yeah, we have not had good access to data. We've asked for hospitalization rates in people under 50 by booster versus non-booster, just the primary vaccine series. We didn't get it. Why? Probably doesn't support the narrative. Science should not be censored or corrupted.
I accept that, but I got limited time, so
yes.
I don't mean to cut you off. Mr. Weissman, you heard Dr. Califf's concern that if you went to an X-Prize model, if you did not sufficiently protect intellectual property, that would be a disincentive for companies to make large-scale investments, et cetera, et cetera, et cetera. Your thoughts on that?
Yeah, I think Dr. Califf is mistaken. In the scenario that you laid out for him, there was no private sector market at all. You were talking about countermeasures where the government was the sole purchaser. So the intellectual property, the monopoly, that's not what's going on. It's not about how we can charge the most for private individuals. All that does is give the company that the U.S. government funded more bargaining power with the United States when we purchase from them. That doesn't seem to me like a sensible thing.
I'm not quite sure I'm following your logic. I think the original premise was that if you're trying to get the company to commit significant resources to developing something, is it better to give them intellectual property? Whether or not the U.S. will be the sole, but in this setting, of course, we're talking about the initial. We've got to jumpstart it. So the premise of the discussion was: is it better to give them an X prize in which you just stake it all, you just bet the farm on winning that prize? If not, you lose. Or is it better to give them intellectual property protection and better to give them some sort of kind of traditional intellectual, et cetera?
Well, I understood that the scenario you laid out to Dr. Califf actually was where the U.S. government was the purchaser. But I think it is an interesting question also where the U.S. government is not. I would actually reverse what you said. To me, the patent monopoly model is the winner-take-all. And it's an uncertain winner-take-all. So the one who gets the patent, that's who's the winner. Don't really know the value because you don't know what the market's going to be. You have more certainty with a prize because you know the value of it. but you can calibrate the prize and share, actually incentivize people to get into space, even if they're not the winner. So you may give an award to someone who drove the research forward, but didn't get the final thing that would have become.
That's kind of a nice group theory kind of approach to it, the idea that everybody would kind of outsource that. I'm not sure that, I can already envision the lawsuits over it's my share, not your share, at least with the patent.
Well, as you know, the patent field is quite full of lawsuits already.
But that's a minefield that's already been well tread and people understand. And Dr. Ramachandran, again, thank you for your good work. Let me just finish by saying this, and maybe any of you could take this. I have a graph showing that there's a reasonable pricing clause in the cooperative research and development agreements, which stopped in 1995. And prior to that point, you had this kind of level of commercialization of research. And then after that removal, there really took off. So it suggests that, in fact, the conclusion of this is the primary stimulus for the increase in the cooperative research and development agreements after 95 was the removal of reasonable pricing clauses, et cetera, et cetera. That's the punchline. Would you disagree with that, or lack of familiarity? If that's okay, if not.
No, I think what you mentioned before of this being possibly an association but not causation comes into play. Also, during COVID-19, we actually did see the use of reasonable pricing clauses, which companies, including major manufacturers, not just small biotech companies that only have one product in their portfolio, accepted. Pfizer was one of them with Paxlovid that negotiated with the U.S. government, and actually within that contract, there was a most favored nation clause, a pricing provision that Pfizer accepted. Similarly, Sanofi and Novavax also had reasonable pricing clauses. And we're also seeing this even outside of the medical countermeasure space. Just recently, University of California, Berkeley, announced reasonable pricing provisions for U.S. populations for their products, and that includes gene therapies that they are developing. So you can see, even for for products where there is a large commercial market, these sorts of protections could be included, and especially for an agency like NIH that has so much leverage and access to technology that companies do want to have.
Excellent answer. I yield.
Thank you. Let me just follow up on Senator Cassidy's point. If I'm not mistaken, I think you called my question an absurd hypothetical.
$100 million.
All right. It doesn't happen. You see, I suggested that people die or get sick because they can't afford medicine. Do you think that's an absurd hypothesis? I don't.
No, it's $100 million, charging me $100 million for life saving.
Not $100 million, $100,000.
I think you said.
Well, cancer drugs are $100,000 right now. All right? So I would like the doctors, I think we have 2 doctors and an expert on it. Is it an absurd hypothesis to suggest that people are dying or suffering or going bankrupt or having their lives disrupted because they cannot afford the outrageous price of prescription drugs? Doctor?
No, it's not a hypothetical at all. It's the lived reality for so many Americans, especially people around the world.
You see it in your practice?
All the time.
Mr. Weissman?
A few points, if I may, Senator. First of all, in the global context we were talking about, it's commonplace. It's the norm.
How many people do we think died because they didn't have access to the vaccine in the world? Do we have a guess?
There are very good estimates of between hundreds of thousands and millions. It's hard to sort of pin it down. And most of those who did get vaccinated didn't get the higher quality mRNA vaccines. In the U.S., second point, in the U.S., as you said, 25 or 30% of Americans actually ration their prescription drugs because of price. Now, not all of them are dying as a result, but some are. The launch price of new drugs right now is $182,000. So $100,000 is not a far out.
Most
it's actually an underestimate.
Somebody correct me if I'm wrong here, but I think many of the cancer drugs that are out there are over $100,000 a year. Is that correct?
That's correct, and some are now going up to $1 million. I just wanted to say one other thing on the question you had asked Senator Cassidy about the CRADA agreement and the reasonable pricing. Actually, what happened there is that in 1995, at the point that NIH stopped using the reasonable pricing provisions in CRADAs, they added a new category of CRADA. So the original category of CRADA were standard CRADAs. These are cooperative research and development agreements. Those stayed roughly consistent after the removal of the reasonable pricing clause. They added a new category of material CRADAs. So the numbers that you're looking at that show this seeming juxtaposition pre-95 and post-95 reflected change in categorization, not the removal of the reasonable pricing clause.
Dr. McCary, did I pose a absurd hypothesis to Senator Cassidy that people are dying or suffering because they can't afford medicine?
The American Cancer Society did a study that 48% of cancer patients say they've avoided or delayed future care for fear of the bill. So that's a real problem. And with the promise of the Affordable Care Act lowering costs not panning out, we now have higher deductibles, creating a new problem called the functionally uninsured. They have insurance, but they can't afford the care.
Exactly right. I don't think, Senator Cassidy, that my hypothesis was absurd.
Well, cancer drugs, of course, have nothing to do with PAPA. Dr. Ramachandran, of course, referred to the global environment. That's different. We can talk about vaccines, lack of availability worldwide. That's a different issue than PAPA. And by the way, most of the patients do have coverage. Yes, there's an occasional who doesn't, but theoretically, Medicare Part D provides coverage for most of those cancer drugs.
Occasionally, few who have no coverage. Is that what you said?
Well, if the Affordable Care Act was successful,
Look, I'm not here to defend the Affordable Care Act.
Well, that's
saying,
effectively, obviously, we're way afield from PAPA.
All right, that's fine. We are, but that's all right. We have 3 witnesses here. Late afternoon, we're having an intellectual exercise here. All right, but with that, I think we both have to catch planes. I want to thank you all for the work you're doing, and thank you very much for being with us. And here's my bureaucratic thing here. For any senators who wish to ask additional questions for the record will be due in 10 business days on May 18th at 5 p.m. Finally, I ask unanimous consent to enter into the record 6 statements from stakeholder groups outlining their priorities for the Pandemic and All Hazards Preparedness Act. Committee stands adjourned. Thank you very, very much.
Thanks so much.